Hello, and welcome to today's webinar. My name is Courtney Dutra. I'm from the Center for Developmental Disabilities Evaluation and Research at UMass Medical School. Working in conjunction with the Massachusetts Department of Developmental Services, we are pleased to present today's topic on identifying, healing, and preventing pressure ulcers. It really does take a village. I'd like to introduce our speaker today. Donna Morrow is an RN and wound care manager for Nozomi Health in Somerville, Massachusetts. She has over 30 years of experience working in nursing and specifically in wound care and wound management. Donna is a certified wound care and ostomy nurse. She's presented nationally on pressure ulcers and published research articles on prevention and care. So without further ado, I'm going to turn this over to Donna so she can begin.
Well, thank you very much, Courtney. I am very happy to be here today and to talk to you about pressure ulcers. This is a topic that I do hold near and dear to my heart, and I spent much of my career treating patients or people with that. I want people to understand that pressure ulcers so that they can give good care to the people that they love and to their clients. Today's objectives will include identifying what pressure ulcers exactly are and what cause them, identifying those most at risk for a pressure ulcer, and recognizing pressure ulcers, especially in different skin tones. We need to know how to prevent and treat those ulcers, and a few case studies and resources. The word of warning, I just want to let people know that today's presentation is very straightforward, as much so as possible, and it's not going to be very clinical. This webinar is primary for direct support professionals and others who work directly with people with disabilities. It is not meant for clinicians. However, we will show some clinical images of what pressure ulcers look like in case you've never seen them before. And we'll limit this to early and medium stages, but you want to be aware that this can be a little graphic. What is a pressure ulcer? Sometimes we call them decubitus ulcers or bed sores, and it's an injury to the skin and underlying tissue. There are two main causes, one being pressure on one spot of the body for too long, and the second being friction on that same skin. Pressure occurs when someone is lying or sitting in one position for too long. The pressure of the body against that surface, like a chair seat, reduces blood flow to the skin and nearby tissue. This stops the flow of oxygen. Pressure can cause damage to the skin and the underlying tissue. And serious damage to the skin and muscle can occur in as little as 1 hour in a chair and as little as 2 hours in a bed. So it's so important to have those people that you love that aren't that mobile help them to move. Even if it's a little bit in a chair or bed, you've succeeded in preventing that pressure ulcer. Friction is a resistance to motion. It occurs when the skin is dragged across a surface. When the person changes position or is moved or repositioned, if the skin is moist or wet, the friction is worse and can cause significant skin and tissue damage. This can worsen existing pressure ulcers. You'll see the highlighted red areas at the buttock and the heel are areas that frequently will be affected by friction. Shearing. It's similar to friction, but it's important you understand how friction and shearing damage the skin. When a person slides down in their bed, the tailbone moves in one direction, downward, while the skin over the tailbone stays in place. This pulls the skin in the opposite direction, and the arrows in the picture show that the bone is moving away one way, while the skin is moving the other. This can cause tearing and damage to the skin. It can also worsen existing pressure ulcers. Can you imagine if you had a pressure ulcer and you were being pulled down in the bed like that? It'd be very painful. Other causes of pressure ulcers, any device or object that sits in the body and presses or rubs against it. Splint, a roll of medical tubing, a G-tube, sheets, towels, or draw sheets. It's very important when placing anything under a client, a draw sheet or anything, that there are no wrinkles, because this can add to the pressure. This can cause a pressure injury. And when you're checking the skin, to be really careful, check all of it. Places you wouldn't normally think a pressure ulcer might occur, behind the ears if a patient's wearing an oxygen tubing. There's not a lot of adipose tissue, so this part of the body can break down very quickly and can go right to a stage 4 pressure ulcer. The impact of pressure ulcers. At first, the affected skin may be reddened or pink. A person may complain of pain or itch, which is an extremely important indicator because that may be your first clue that something's wrong. In a darker toned skin patient, you may not see the redness or pinkness, but that pain can give you an indication to touch or to feel that area for bogginess or for softness, firmness, warmth, or coolness. This can be an indicator that a pressure ulcer is forming. And if that area is left untreated, the skin can open, become larger, deeper, and much more difficult to heal. This goes into great pain and can lead to bone infection and sepsis. I'll go into that a little more on the next slide, but this area can lead to death. Septicemia or sepsis infection, it is a serious life-threatening condition. It occurs when the body has an overwhelming immune response to that infection. As you can see in the picture, your client might complain or have shivering, a fever, or feel very cold. They may have extreme pain or general discomfort. They may be pale or have discolored skin. They may complain of being sleepy, or they may be difficult to wake up or be confused. And they might state, "I feel like I might die." That's how bad sepsis would make your client feel. They might not be able to explain it. That might be something they might say. They also might be short of breath. These are some data from research studies. As many as 1/3 of hospitalized patients with pressure ulcers die during their hospitalization. More than half of those who develop a pressure ulcer in the hospital will die within the next 12 months, and about 60,000 patients die a year as a direct result of pressure ulcer each year. And this translates to 6.85 deaths every hour, every single day. So pressure ulcers are a huge impact on healthcare and the people we love. Okay, now that you know what a pressure ulcer is, what causes them? I'm going to cover who is most at risk for developing these, and you can probably already think of some situations where people would be more likely to develop a pressure ulcer. People at risk are the elderly, people who have lost feeling or sensation in a body part, cannot move themselves, are immobile, sit or lie down for extended periods of time, or have a history of pressure ulcers. Also, clients that have bowel or urinary incontinence. And the elderly are more at risk because of the skin loss elasticity as it ages. The skin can't bounce back, and they're more likely to suffer a skin injury or a tear. More people that are at risk are people that take 8 or more medications, have poor health, chronic health conditions, especially diabetes and blood circulation problems, poor nutrition and hydration, making sure that your patient is getting a high protein diet with lots of water. They really need to be hydrated to keep that skin healthy. Fragile skin that tears easily, skin tears or chronic skin problems, and excessively dry or moist skin. Sometimes we use too much moisturizers or lotions over the counter. We need to have a balance because sometimes moist skin can be just as dangerous as having dry skin. People with a history of pressure ulcers, they are 5 times as likely to develop another pressure ulcer. The strength in that skin after you've had your pressure ulcer and it's healed goes down to 70%. So you're never going to have that full strength skin that you did after a pressure ulcer. So much more likely to break down again. We need to really be aware when we have a patient that's had a pressure ulcer. They especially need to be repositioned off of that area. And even if the skin and muscle heals, like I said, it will never be as strong as it once was. How to recognize a pressure ulcer. Now that you know what a pressure ulcer is and what causes them, I'll cover what a pressure ulcer looks like and where to look for them. 95% of pressure ulcers develop in the lower body. Common sites, as you can see on the picture, are the tailbone, the hip bone, heel, ankles, elbows, and spine, as well as the back of the head, and areas we don't think of too much, back of the ears. These are all in red on this picture, you'll notice. What do pressure ulcers look like? These are both examples of pressure ulcers in the pictures. Notice that the skin doesn't have to be open for a pressure ulcer to exist and for significant damage to be occurring.
In the early stages, the skin can appear red or inflamed, and the person often complains of pain or an itch in the affected area. The skin may be intact, but it is red or spongy, and you need to be aware that pressure ulcers can look different on different skin tones. The stage 1 is where we want to find the pressure ulcer. We want to see that we have a problem, get that pressure away from it, and make sure it doesn't go any further. This is where it's so important for you to check the skin and alert someone right away. A charge nurse, your supervisor, your agency nurse, let them know and say, hey, I see a red spot on my client.
Okay, the next slide, finding ulcers, look, listen, and feel. Very important. You need to check your client's skin. Close range and at a distance, you'll be able to pick up differences in their skin tone. It can give you a heads up that a pressure ulcer may be forming. You need to listen again to your client if they're complaining of pain or soreness. Very important. And to feel, touch the person's skin. Check for warmth, coolness. If it feels mushy or firm, anything that might feel different to you, it might be an indicator that something's wrong, and to let someone know. See something, say something. Very important. It's not going to help anyone if you see something and you go, I'm going to keep an eye on that. You need to take the time, let somebody know, whether it's a doctor or a nurse that visits, the head of the group home, whatever it may be. You want to make sure that patient's seen by a medical professional or a wound nurse, somebody that'll know if that difference that you've seen is something to really worry about. Stages of pressure ulcers. The average person doesn't need to know much about the different stages. You don't need to know the different stages to identify a pressure ulcer. This is how medical professionals describe them. You're probably going to hear these terms, so it's good to understand what they mean. There are different stages of pressure ulcers, stage 1 being the least serious and 4 being the most. But medical professionals will use this word staging, so it's important for you to understand that. Stage 1, you notice that the skin is not broken, but it is inflamed. The area may be red, painful, soft, firm, warmer, or cooler.
Stage 2, the outer layer of skin, epidermis, and the inner layer of skin, dermis, is damaged or lost. The wound may be shallow, pinkish, or red. It may look like an abrasion, fluid-filled blister, or a shallow crater. In stage 2, the wound will be open.
In a stage 3, the loss of skin usually exposes the fat layer. Bone, tendon, and muscle are not exposed. Oftentimes, you'll only see part of the wound. It may be actually a lot deeper. There may be damage underneath. Pressure ulcers start at the bone and they work their way outward towards the skin, and by the time you see it, it's already been working its way out. Stage 4 is the pressure ulcer at a very deep, severe stage. It reaches into the muscle, the bone, and it causes extensive damage. Damage to deeper tissue, tendons, and joints may occur. What do pressure ulcers look like in different skin tones? Darker versus lighter skin pigmentation. The most crucial part of detecting the pressure ulcer is understanding the changes in skin.
A pressure ulcer may appear bluish, purplish, or violet in darker pigmented skin. The same ulcer would look red or pink in lighter skin. That's why it's so important to do a tactile exam and feel the skin. You might not be able to see everything that's below the skin and happening. When you feel the skin, you might feel that the area feels boggy or very soft. It will often be a different temperature from the surrounding skin. It may be warmer or cooler. These are good indicators there's a problem and to alert someone. How to check for pressure ulcers in darker skin tones. The skin may be taut, shiny, or hard, firm. Feel the area to see if it feels boggy or very soft. It will often be a different temperature from the surrounding skin, and again, the person will likely be in pain. It's important to identify these areas before they develop into a larger pressure wound.
How to prevent pressure ulcers. Great way to prevent them is early detection. Inspect skin during bathing or daily personal care, and to report any and all changes in skin appearance. Do not massage areas that are already red, especially if they are over a bony part, body, ankle, hip. We want to be able to pass that on to somebody in charge, let them know. Reporting, I think, is the most important thing you can do. To protect the skin, we want to make sure that we're checking for urinary and fecal incontinence so that a person is not sitting for long periods of time. Feces and urine can be toxic to the skin. It can affect the pH balance, and it can definitely affect breakdown of skin. It also removes the protective layer that the skin normally has. So it's so important to properly clean the skin and then re-moisturize after. We want to use only creams that are ordered by the physician. Over-the-counter protectants are fine, but you really need to make sure that we have healthcare involved in choosing which ones. Good hydration and nutrition. Again, protein is the key. It's so important when you're helping your client to choose foods. We want to choose a high protein. We want to make sure they're drinking throughout the day. Protein is the biggest builder to skin and healing. We need to maintain that hydration and nutrition. Clients need to drink enough, they need to be hydrated, and they need to choose things from a healthy diet.
Good positioning. When in bed, maintain the lowest possible head elevation appropriate for that person to reduce the impact of shear. Position the patient to minimize pressure and shearing forces over the heels, elbows, base of the head, and the ears. Remember, positioning a patient is always appropriate for that person. You need to follow guidelines as needed for that person. If a patient has a G-tube and they're getting a feeding, please follow the doctor's orders and don't put the head of the bed down. We always want to maintain what the doctor suggests is the safest possible positioning for that patient.
When repositioning, we need to help the person change position to relieve the pressure on that body part. Person should change position at least every 2 hours and more often if they're at risk for pressure ulcers. You can gently help your patient if they're in a chair or in a bed. You can use pillows under one side of the back to offload pressure, cushions under legs or between knees. And we need to follow all health practitioners, physical and occupational therapists, and nursing orders. There are reasons sometimes that we have to have a patient, again, positioned at a certain level, and we can't change that without a doctor's order. We want to minimize friction and shearing. We want to avoid dragging those heels, hips, or a tailbone when we're lifting someone in the bed. If they have a device like a trapeze, please let them use that, let them assist you, because that can cause a pressure area. Wheelchair repositioning and assessment. It is so important to encourage patients to shift their weight every 15 minutes while seated. And if you have a tilt feature on your chair, it's very simple. Move it a little bit. You've taken the pressure, you've changed it. That little bit that you're doing will help that pressure to be relieved, and the patient won't develop that pressure area. We need to inspect the cushions for signs of wear, proper inflation, proper placement. Wheelchairs, they need to be inspected. This says daily, absolutely. A sharp edge could cause a brand new wound or injury, and we don't want to cause injury. We want to prevent it. Providing good support. Specially ordered air mattresses or wedges, cushions, or pillows will relieve the pressure. If your patient has a pressure injury, they may have an air mattress. Make sure that it's properly inflated. This support is needed to offload that pressure, and they would be recommended by a doctor, a physical or occupational therapist. Skincare, very important. We need to keep that skin clean and dry. We need to wash with mild soap and water, rinse thoroughly, and gently pat dry. We can apply over-the-counter lotions to prevent that dryness or skin breakdown. And again, never massage over the red skin, we want to make sure that that's left alone. We don't want to add to any pressure on that area. Pressure ulcer management. All wound care is to be managed or overseen by a certified wound and ostomy nurse under the order of a healthcare provider. An individualized protocol for the prevention and management of pressure ulcers must be created for any person determined to be at risk. We want to make sure that somebody that's a professional that works with wounds, or a physician that works with wounds, makes that plan and lets us know what's safe for this patient. We don't want to change anything without a doctor's order. This is the Braden scale. It's a way that healthcare professionals judge the risk of a person having a pressure ulcer. You may see these in the home or hear them discussed.
Braden scale assessments are not completed by direct care staff. It is a tool for licensed staff only.
Everyone has to be involved. As you know, this is a team approach. Planning to provide evidence-based treatment interventions is the responsibility of the whole team. Whether you're the nurse, the case manager, a family member, or a direct caregiver, you're important and your input counts. We all need to be on board to prevent pressure ulcers. Pressure ulcer treatment. The treatment of a pressure ulcer will be done by a wound and ostomy nurse, not the provider nurses or direct care staff. However, your input is extremely essential. We need to know if there's a new reddened area or if the wound smells different or looks different to you. Treatment and monitoring. A healthcare professional should evaluate a pressure ulcer at every dressing change to assess. But even though the wound and ostomy nurse is managing the treatment of the wound, direct care staff probably play the most essential role of all, that of noticing the beginning of a pressure ulcer and reporting it immediately. You can stop the process. All right, treatment goals. An open pressure wound needs to be covered by a dressing. We need to keep that wound bed moist and the surrounding skin dry. We need to protect the ulcer from contamination and promote moist wound healing. If you find a wound, it's better to cover it than leave it open. We don't want to get an infection. I have a couple of case examples that I'd like to share with you. These are clients that I cared for. Case 1, I had a 57-year-old male who was admitted to the hospital with pneumonia and sepsis. This person had to be intubated while in the hospital and developed a stage 4 pressure ulcer as a result. Normally, this person was active and not a person who we would think would develop a pressure-related injury. But because he was made immobile related to intubation and hospitalization, that pressure wound developed rapidly. That wound changed his life. It interrupted it for over 6 months. He had difficulty sitting for a prolonged period of time, and he was in a lot of pain. He was very self-conscious of this wound, and it could happen to anyone that's hospitalized. That's why we need to be aware that if you have somebody in the hospital, or even if you're in the hospital, make sure that we're being positioned even a little bit. We might be able to prevent something like this. Statistically, hospitalizations and illnesses increase that chance for every person for developing a pressure ulcer.
Case 2, 61-year-old male with a history of diabetes, kidney failure, and arterial disease. He had an amputated leg and he wears a prosthetic device. Developed a blister on his right leg above the knee amputation step that turned into a stage 2 pressure ulcer. This was caused by wearing his prosthetic device while his stump was edematous or swollen. And as you can see in this picture, because the stump was swollen, applying that prosthetic device to it caused that pressure ulcer. You wouldn't normally think of a pressure ulcer developing in that area, but a pressure ulcer can develop anywhere it comes in contact with a hard surface, including a prosthetic device or a brace. When doing a daily skin check, we need to check the skin before we apply any braces or hardware because we can actually cause a pressure wound. And in this case, it may have started a red area that could have been treated rather than it developing into a stage 2 pressure ulcer.
Thank you, Donna. This is Courtney Dutra again, and I wanted to wrap up the webinar by sharing some places where you can find more information. DDS, the Department of Developmental Services, released guidelines for managing pressure ulcers, and these were released in June of 2017. Basically, the guidelines state that all people with risk factors for developing pressure ulcers should be evaluated, and a protocol should be created for how best to manage that risk. Additionally, all wound care should be managed by a certified wound and ostomy nurse. And there we put the URL if you'd like to go read those guidelines more in detail. Additionally, DDS developed a signs and symptoms sheet. This is a 1 or 2 page sheet that's very basic, very straightforward and clear, and really gives good information about what is a pressure ulcer, what does it look like, who is most at risk, and what should you do if you suspect somebody has one. So I would really recommend that everyone visit the DDS website. We put it there at the bottom, and print off a copy of that for yourself. We also have something called the Quality is No Accident Brief. This is developed by my research center as well as DDS, and this is really targeted towards house managers, risk manager, program supervisors, and it goes into just more detail about risk factors. And so how to identify risk, how to best manage that risk, as well as some treatment and prevention strategies. And again, we put the website there if you'd like to get that. And here we have general resources about pressure ulcers, and we will also post this on our webpage with this webinar. Lastly, I'd just like to say thank you for listening today. If you have any questions, Sharon Ox, the Director of Health Services for DDS, has made herself available to answer questions by email. Her email address is Sharon, SHARON, .ox, OXX, @state.ma.us. Thank you for listening.